So let's start another fresh topic, that is stridor. This is also an important topic in pediatric age group because there are some important conditions which may present to the hospital with stridor. Stridor is a type of noisy breathing. It's a harsh type of noisy breathing where upper airway is blocked. Okay, it is a much more harsher in comparison to wheeze. Now, so this is a harsh noise produced by obstruction in larynx and trachea, and there are different types of the stridor according to the site of obstruction. Inspiratory stridor, if the obstruction occurs above the vocal cord, we call it supraglottis. Expiratory stridor, when the obstruction occurs in the distal part of the trachea, and biphasic, when exactly the region of the glottis or near to that is obstructed. So inspiratory, expiratory, and biphasic. But frankly speaking, the most common cause of stridor or type of stridor, I should say, is inspiratory one. Now, uh, let's talk about some of the differences between supraglottic versus tracheal obstruction. So, what type of findings are there in supraglottic obstruction and tracheal obstruction? See here. In supraglottic obstruction, usually there is inspiratory stridor, means stridor is heard during inspiration, whereas in tracheal or distal tracheal obstruction, there is expiratory one. Cry is muffled. In glottic, the cry is weak and hoarse, because glottic means it's a larynx, and larynx is the area which produces the voice. So there is a hoarse and weak voice. Whereas in tracheal obstruction, there is nothing, no connection with the voice, so voice is normal. Dyspnea is less severe in supraglottic obstruction, whereas dyspnea is much more severe in tracheal obstruction. And cough is less marked in supraglottic, whereas deep barking type of cough is present in tracheal obstruction. Remember, a disease known as acute laryngotracheobronchitis, there larynx, trachea, and bronchus, all three are inflamed and getting narrow. So a barking cough is a hallmark of that condition. So that is the way to remember. If somebody asks you this question, then you can say deep barking cough. Now let's talk a bit clinical here. How to evaluate this type of baby who presents in the hospital with stridor sound. We take a good history, okay, ask about what is the age group of that baby or the child, what is the age group. So what is the important point about that? Okay, the Croup syndrome occurs in very small babies actually, and epiglottitis and other occurs in slightly older one. History of cough, cold, fever, and other associated symptoms like history of choking, aspiration, and foreign body ingestion, they are always asked. One of the important differential diagnosis of stridor is foreign body aspiration or foreign body ingestion. So this is a very important question. Don't always bias. Okay, this is a case of croup or epiglottitis. There may be some other also. When we talk about the causes, then you are quite clear. Ask about the past history of similar episode or from what is the duration. It is occurring from birth time or later on. If it is occurring from birth time, maybe there are some congenital anomaly which are causing obstruction of the airway. Ask about the vaccination. One of the important vaccine which has connection with this is HIV vaccine. Okay, HIV, Haemophilus influenza type B vaccine. This vaccine is very, very useful for the pediatric age group. Okay, and these days many of the countries, they have included this vaccine in their EPI schedule as well. Now remember, what are the infection caused by Haemophilus influenza? Quite a common question. And one of the disease is in connection with this topic, that is acute epiglottitis. That's why we have included this point here. But you should remember other disorders also, like meningitis is commonly caused by Haemophilus influenza type B. Pneumonia is caused by that organism. Sepsis or septicemia is caused by that. and otitis media can also be caused by that. So these are the other infection. Asks about the epidemics of influenza or parainfluenza in that area. Now, some of the parents, know the name of these disorders, but some other they don't know. So asks about, are there many kids or many children in that area who are getting fever, okay, and cough? This is the indirect way to ask question, because influenza and parainfluenza viruses can easily lead to this type of infections. Now, let's talk about what are the causes of stridor. The common causes are Croup syndrome. Now, Croup syndrome is very common in children. It is caused by, okay, mainly viruses, and it is also known as acute laryngotracheobronchitis. See there, larynx, trachea, and bronchi all are inflamed. Acute epiglottitis is another common disease. Acute bacterial tracheitis, now involvement of trachea by the bacteria, and even foreign body obstruction or aspiration, inhalation. These are more common causes than other regarding stridor. Now, what are the other causes? They are relatively uncommon in comparison to those four, but they are also important. Remember, they are though uncommon for the doctors, but for that baby, it is 100%, isn't it? If a baby gets a stridor because of any of these causes, it's our job to find that out. So what are these? Severe infectious mononucleosis, which is caused by Epstein-Barr virus, though this age group, which we are talking, very small babies, this infectious mononucleosis is not common in them. This is more common in adolescent and young adult. But if an adolescent comes to the hospital with stridor, then probably this may be the cause. Peritonsillar abscess, also known as quinsy. Now, this is the abscess formation in relation with tonsil, a very painful condition. There is high-grade fever, and that person cannot swallow at all. There may be drooling of saliva in this type of condition. Okay, diagnosis is very easy. Okay, and treatment is incision and drainage along with tonsillectomy after around 6 weeks. Retropharyngeal abscess is another condition where there is a collection of pus in the retropharyngeal area of the pharynx. Now, two common causes are there. One is bacteria, that is pus forming or pyogenic bacteria. Another is Mycobacterium tuberculosis. Now, bacteria can cause acute abscess formation, and tuberculosis is always a chronic one. Another cause may be chemical or extensive skin burn, which may result in laryngeal damage or laryngeal edema. Laryngeal damage or laryngeal edema. So that can be there. Tetany, okay, tetany. This is not tetanus, this is tetany. This tetany is caused by hypocalcemia, and hypocalcemia can lead to twitching and spasm of different body area. So airway can also result in obstruction. Diphtheria, caused by Corynebacterium diphtheria. Okay, usually the upper airway are affected near the tonsil area. Sometimes even larynx can be involved. Mechanical trauma to the upper airway and secondary to mediastinal tumor, they can also give pressure and can result in obstruction. So these are considered a differential diagnosis, or you can say causes of stridor. So a good history is necessary. Now, after taking the history, let's examine that child. The first thing is vital sign, and let's measure it. What is the pulse rate? What is the blood pressure? What is the temperature? What is the respiratory rate? And what is the oxygen saturation? And that is done by pulse oximetry. Now remember, in this case, okay, because we are talking about stridor, so respiratory rate and pulse oximetry are more important than other. Having said that, pulse rate is also high if a baby is hypoxemic. So pulse is also important here. So all vital sign we should take all the time. Look for cyanosis. Cyanosis is a feature of severe hypoxemia. Look for signs of dehydration. If fever is high grade, if the child is breathing faster for a long time, then fluid may be lost from the body. that can simply lead to dehydration. Palpate for the neck node. Okay, it may be a feature of diphtheria, for example. Diphtheria is also known as bull neck appearance. So there are lots of nodes in the neck. Nasal flaring. Look for the nasal flaring and other manifestations of respiratory distress, like supraesternal or intercostal retraction. Okay, then flaring of the alveoli, which is called nasal flaring, subcostal retraction, even use of sternocleidomastoid and trapezius muscle. These all are features of respiratory distress. Examine throat and pharynx directly or with the help of some instrument like laryngoscope. Now, this will give us the diagnosis. If there is epiglottitis which is going on, now examination directly by laryngoscope, okay, without general anesthesia or without any intubation set or tracheostomy set may be quite dangerous, because that time the baby is already scared, and on top of that, if you forcefully do this type of examination, the airway will develop spasm, okay, and the baby may die because of hypoxia. So what I want to say here is, you definitely examine, okay? Examination is important, but be prepared. If something wrong or something worse happen, then you should be able to tackle it with necessary instrument there, necessary people there. So that is the meaning. Examine for the chest, examine for bilateral air entry inside the chest, and examine for added sound. For example, in croup, there may be some added sound there, right? In case of foreign body inhalation or aspiration, there may be added sound on one side of the lung. So these are the important points. Examine for level of consciousness in the baby. If the baby is too hypoxemic, then the baby may lose consciousness level. In the beginning, the baby may be irritable or a bit lethargic. Now, what are the investigation you like to do in a case of stridor? Now, see here. Do X-ray neck, AP and lateral view. AP and lateral view. AP means anterior-posterior. Now, this is done mainly to rule out foreign body. Another important types of X-ray, okay, is soft tissue X-ray. So only soft tissue view is shown there preferably, and this is very, very important if you are suspecting some pathologies there, like abscess. Chest X-ray is the must, always done. Blood CBC and culture and sensitivity, okay, is very, very important. I want to give you one example here. In case of acute epiglottitis, this is caused by Haemophilus influenza type B. So there is leukocytosis with neutrophilia, and usually that organism can be grown from the blood culture also. And after it is grown, we can go for sensitivity test. Examine for, okay, gram stain and microscopy by taking throat swab. So if you are lucky enough, you can see that bacteria which is causing the infection. Again, I'm talking about Haemophilus influenza type B. And don't forget to go for culture and sensitivity. Now, with this information, let's talk about some of the conditions now. The important one, and I have chosen 3 important conditions here. These are Croup syndrome or acute laryngotracheobronchitis, then acute epiglottitis, and at last acute tracheitis. The first 2 are more important than the last. Now, Croup syndrome or laryngotracheobronchitis is very common in 1 to 5 years. The peak is 2 years. Okay, means very small babies are affected, and this is the most common cause of acute stridor. So whenever the typical barking type of cough and this noisy breathing, okay, comes to the hospital, the first thing that comes in our mind is this is a case of croup. So the common causative organisms are parainfluenza virus, respiratory syncytial virus, influenza virus, adenovirus, and rhinovirus. Parainfluenza, RSV, respiratory syncytial, influenza, adeno, and rhino, and any other viruses which leads to infection of the respiratory tract may be there, like coronavirus as well. Now, what are the presentation or sign and symptoms of Croup syndrome? In the beginning, there may be coryzal symptom. Now, this coryza is common cold symptom which may last for 1 to 2 days with mild type of cough and hoarseness of the voice. Now, this hoarseness of the voice is because of laryngeal involvement. Okay, remember that whenever hoarseness of the voice occur, that means there is inflammation in the larynx or affection of the larynx. Barking cough is one of the hallmark of Croup syndrome. Okay, barking cough like a dog. Okay, that typical type of cough is produced by the child. And let me tell you one clinical scenario. You are working in emergency department or emergency room. Okay, uh, in the night you are doing duty there, and suddenly a baby was brought there, around 2-year-old baby. Parents are very, anxious. The baby was coughing. This typical barking cough was there, and without any doubt you can clinch the diagnosis just by listening that cough. It is Croup syndrome. Stridor starts at night or sun cry or when disturbed, and stridor is usually biphasic. So it starts at night. That is the scenario I just gave you. Okay, when the child is anxious or afraid, okay, then uh, it will become worse. The stridor become worse. So we should keep the baby cool and calm. Don't separate the baby from mother. Okay, during your examination, it is always advisable to examine the baby on mother's lap. Sternal retraction and use of accessory muscles are there. This is the feature of respiratory distress. The baby may become restless, anxious, and breathing fast due to increasing hypoxemia. I already told you in the earlier stages of hypoxemia, the baby is restless. Okay, the baby is irritable, anxious, and having tachypnea as well. Cyanosis is a late feature, and as the obstruction worsen, okay, now see here, the breath sound may become inaudible and stridor apparently decreases. And some of the doctor may become happy if the baby is showing this type of feature. But this is not the moment for happiness. This is a moment for emergency procedure, because the airways are clamping down. They are severely obstructed here, and no movement of the ear is occurring. That's why I cannot hear any breath sound. So this type of child needs, intubation and the further management. Pyrexia may be mild or absent. Pyrexia may be mild or absent in this type of condition because it is mainly a viral infection. Now, how we confirm the diagnosis? We confirm the diagnosis by clinically examining the baby as well as doing the X-ray. And that X-ray, if we take the lateral, neck X-ray, then subglottic narrowing, or which is also known as stipple sign, is seen. Okay, subglottic narrowing, also known as stipple sign. Now, this is at the level of cricoid cartilage. If we see that, then there is acute narrowing of the airway, that is called stipple sign. Now see here, okay, this is the stipple sign here. This I can clearly see the column of the ear, but at this exact area, okay, I can't see it properly. So stipple sign in the X-ray. Now, how to manage a child with Croup syndrome? What's the type of management we like to do? Humidification of environment. Okay, humidification of environment by warm mist or steam should be done, because if the baby is inhaling dry type of air, okay, it will further cause the problem. So humidify the air. Admission is done in the hospital in this type of situation. If there is high grade fever, if you are confused with any bacterial infection, if the baby look toxic, or if the baby is hypoxemic, okay, then admit in the hospital. Monitor heart rate, respiratory rate, severity of stridor, degree of retraction of the chest, color of the baby, and level of consciousness. These all features will tell you how severe is the baby. Okay, it will show the severity of the disease. Give oxygen, the humidified oxygen, which is administered through the tent. Now, what's the meaning here? Don't give dry oxygen. Okay, give humidified oxygen administered in the tent. If I directly apply mask on that baby, remember this baby is already apprehended. This baby is already a little bit scared. Okay, if I put the mask, the baby will be more scared, and the baby will easily throw that mask away. So better thing is give the oxygen through the tent. Okay, so that whole environment will be baby friendly. Avoid sedation. If a very restless baby, we want to give chloral hydrate, because most of the sedation, they can cause respiratory depression, and this is not the time when we depress the respiration. So chloral hydrate is a good option if the baby is very restless. Epinephrine can be given through nebulizer. This epinephrine, okay, remember epinephrine is sympathomimetic drug, a vasoconstrictor drug, and this edema in the airway is because of vasodilation. So if we give epinephrine through the nebulizer, it may help during this time. And we can also use steroid. Okay, we can try steroid like single dose dexamethasone or nebulized form of budesonide. That can be tried. They can also decrease the extent of inflammation there. What are the other modalities of management? 80% helium can be mixed with 20% oxygen and given. This will decrease the density of the airway and the baby can breathe easily. Okay, this is important point. And 1% of the child need intubation. 1% of the child may need intubation if they are very sick. For example, if the airways are completely clamped, if there is no airflow inside, then we have to go for this type of management, intubation or tracheostomy. Intubation can be done by two ways, nasotracheal intubation and orotracheal intubation. In case of a small baby, nasotracheal intubation is better because it is stable. The baby cannot remove that tube easily. Only that reason. Otherwise, orotracheal is fine. Antibiotic is not needed here because this is a case of Croup syndrome and it is caused by viruses. But if you suspect secondary bacterial infection, just go for it. Okay? Don't hold yourself. And extubate after 2 to 3 days if the baby is doing well. So these are the different management options for Croup syndrome. Now the second important part of today's lecture is acute epiglottitis. Now, this is even more serious than Croup syndrome because this is caused by a bacteria known as Haemophilus influenza type B. This is the most common organism. And the peak age is 2 to 3 years. These babies are slightly older than Croup syndrome. And regarding the presentation, there is a high-grade fever and the baby becomes acutely ill with toxic changes. The face becomes very red. Okay, the baby looks quite sick within a short period of time. The acute onset of severe inspiratory stridor can be heard, and the parents are quite worried about it, and they quickly bring the baby to the hospital. And by the time the baby reaches hospital, when you are examining that baby, you also find the baby very sick. Now, what are the other findings there? Okay, the child appears anxious, means afraid. Swallowing is very painful. Even saliva cannot be swallowed. So there is drooling of the saliva from the angle of the mouth. This is one of the very important feature we note in the hospital. And muffled voice, or the baby may not be able to produce any voice because of the extent of infection towards the larynx. Now, how to make a diagnosis of acute epiglottitis now? Diagnosis is mostly clinical. Okay, it is mostly clinical. When we do X-ray of the neck, the lateral view, we can visualize the epiglottis. We can visualize the epiglottis and it is swollen. Okay, it is swollen. This is called thumb sign. X-ray of the neck, the lateral view, can visualize epiglottis which is swollen there, and this is thumb sign. But one important point here, it may be quite hazardous to take the baby for X-ray in case of emergency situation like this, because in the X-ray room there may not be any doctor, and if the baby's airway become clamped, okay, become shut down or completely blocked during that time, then nobody is there to revive the baby. Okay, so always accompany this type of baby if you really want to do X-ray, or even better thing is ask that person to come to the emergency room to take the X-ray right in front of you. Okay, these portable X-ray machines are available. Now examine the baby under general anesthesia, GA, with intubation and tracheostomy set ready. If you need it, you can quickly go for that. That is the concept. And when you examine, the epiglottis is very red, very swollen, and we call that angry epiglottis. And this is the diagnostic feature of acute epiglottitis. Now, regarding the management, this type of sick babies are admitted in the hospital. Okay, admission is done. Then they mostly require intubation to secure the airway. In more than 60% of the time, they cannot secure their airway on their own. So we need to intubate them. Okay, and especially if they are having cyanosis or severe hypoxia, this is always done. Give antibiotic. Okay, give antibiotic as soon as possible. This is a severe bacterial infection, so IV antibiotic is immediately given, and there are two choices for us: cefotaxime as well as chloramphenicol. Now, if you ask me, I'll always choose cefotaxime, okay, over chloramphenicol, because it is a safe drug, doesn't have much side effect profile, whereas chloramphenicol can suppress or depress bone marrow. That is a very severe type of side effect. Role of steroid is not very clear because this is a bacterial infection. Okay, it is not very clear. So if you are not sure, don't give it. And once intubated, the baby may be kept for 12 to 24 hours to settle the inflammation. And after that, we can extubate the baby, but continue the antibiotic. Now, this is called thumb sign. Okay, this swollen area, this is called thumb sign. So this is one of the important point in acute epiglottitis. Now let's differentiate okay, between epiglottitis and Croup syndrome. So this type of questions are very commonly asked in the exam. Okay, see here. Regarding the organism, it is caused by Haemophilus influenza type B. It is caused mainly by parainfluenza viruses, but other viruses are also involved. Regarding the age, this epiglottitis is relatively older than the Croup syndrome baby. Temperature, this is bacterial infection, so it is high grade fever. Here is low grade. Regarding the dysphagia, difficulty to swallow, in epiglottitis it is very severe. The baby even cannot swallow the saliva, whereas in Croup it is absent. The baby can swallow easily. Dyspnea is very pronounced in epiglottitis, and in Croup syndrome it is variable. And some of the baby may be quite dyspneic, some others are not that much. Drooling, already talked about, present in epiglottitis, absent in Croup. Lymph node swelling are commonly occurring in epiglottitis than in Croup. Cough, not common in epiglottitis, but a barking cough is seen in Croup. Okay, this is very important point, barking cough. So these are important hallmark. This drooling, okay, drooling present here, important feature. Barking cough is important for Croup now. Voice is muffled in case of epiglottitis. It is hoarse in case of Croup. Hoarse and muffled, two different things. Posture, the baby is sitting forward to maintain the airway, and the baby is lying down here. The sitting forward position is very typical in case of epiglottitis. Behavior, the baby is quite terrified, okay, very afraid, terrified type of appearance. And here, because of hypoxemia, the baby is struggling. And One more thing, okay, if you take the X-ray, in case of epiglottitis, it is a thumb sign. In case of Croup, it is steeple sign. Now, one more, part of this topic is left, which is acute tracheitis. Let's learn about this. This tracheitis is acute inflammation of the trachea. See there, and it is also known as pseudomembranous croup. Pseudomembranous croup. It is less common than laryngotracheobronchitis and epiglottitis, and it may follow viral URTI in children. Now see that upper respiratory tract infection, which is very common in children. Now how this type of condition occur? In the beginning, there is URTI, and the baby may present with low grade fever, mild cough, okay, runny nose, and a bit of congestion in the throat. After a few days, that low temperature can become very high grade fever, okay, and presence of the stridor. So this is a case of acute tracheitis, and it is mostly caused by Staph aureus. Staphylococcus aureus is the usual causative agent in this case. Occasionally, Haemophilus influenza can also cause the problem. Regarding the presentation of this condition, there is fever for 2 to 3 days, and this fever is moderate to high grade because it is caused by Staph aureus. Now the child looks toxic, sick looking, with brassy type of cough and inspiratory stridor. The type of cough which is present in acute tracheitis is called brassy cough. There is purulent tracheal secretion in tracheitis, and there is extensive inflammation in the trachea with copious secretions, okay, coming from there, and this secretion is mainly pus, but there are no gross epiglottic changes on laryngoscopy, because this is not isn't it, a disease of larynx. So there are no changes on laryngoscopy. The disease is a bit deeper than larynx. Now regarding the diagnosis, it's mostly clinical, and if you do laryngoscopy, okay, then you won't see anything. That means it's a diagnosis of exclusion. You rule out uh, epiglottitis and croup, then probably you can say, yes, this looks like tracheitis, and make intubation and tracheostomy set ready if the baby will become breathless during a laryngoscopic exam. Regarding the management, virtually all children require intubation or tracheostomy because trachea is acutely inflamed. It is full with pus, so there may be a feature of obstruction there. Frequent tracheal toileting has to be done. This means cleaning, okay, cleaning of the trachea. ET tube or endotracheal tube, sometimes it may be necessary to keep it for a longer period, and antibiotics, the mainly anti-staphylococcal antibiotics are given here, like flucloxacillin, floxacillin, napcillin, isn't it? These are the common example. If you are in doubt, straight away go for vancomycin as well. Now at the end, okay, some of the key point from this topic, which will give you a bit of summary also. Acute stridor is a life-threatening emergency. Never ignore it. If you ask me, out of 3 or 4 respiratory noises, which is the most severe one, I always choose stridor. Okay, stridor is the most severe one. Fast clinical assessment and airway management is necessary, okay, in the hospital. You quickly judge what is the airway. Can the baby, okay, manage the airway on his or her own or not? If not, then secure the airway, probably by endotracheal intubation. Don't leave the child unattended till airway is secure. Child may collapse anytime. So this is very, very important point. Throat examination and laryngoscopy should be done, okay, with all the set ready in front of you. So intubation set should be ready, tracheostomy set should be ready. Without that set, if airway gets blocked or clamped down suddenly, you cannot do anything. You may lose the baby. Adrenaline nebulization, injectable steroid, and oxygen are the first step during the management. Now, why adrenaline? Because it is a vasoconstrictor. It can decrease the edema of the airway. Steroid are anti-inflammatory, and oxygen because of hypoxemia. So all of these are important point. X-ray is not indicated until suspicion of foreign body aspiration, because X-ray is not giving you important clue there. Okay, the important point we get from the examination. So this is important point, and if you want to do X-ray, please accompany to the X-ray room and stay there until and unless you complete it. DPT and hip vaccines are important to decrease the cases of acute stridor, and we are doing this all over the world these days, but still so many cases of stridor are happening because of incomplete vaccination. So at the end, okay, as always, these are the questions I prepared for you, so go through them confidently and solve them.